results. Yay, Renin-Angiotensin-Aldosterone System, first proper introduction, okay? The RAAS is the most important system to understand in terms of blood pressure, okay? Yes, there are other things that affect blood pressure. We've talked about a number of them. We're going to keep talking about them. The RAAS is important because there's a number of spots in here that we target with our antihypertensive medicines. Okay, that's why I really want you to learn the RAAS. All right, so here's how this system works. A decrease in arterial pressure for whatever reason, okay, the kidney pressure filter, it needs pressure to work. So when the kidney doesn't get enough pressure, it releases renin, or renin, depending on who you ask, okay? I say renin, so you're going to have to deal with that. Okay, so renin is released. Renin is an enzyme, and it catalyzes the reaction of transforming angiotensinogen. Remember, when you see ogen, that's a precursor, right? Biological precursor. So angiotensinogen is converted to angiotensin 1 by renin. Angiotensin 1 is converted to angiotensin 2 in the lungs by the angiotensin converting enzyme, the ACE enzyme, as in ACE inhibitor. We have a medication that blocks this enzyme, okay? Why do we love those medicines? Because angiotensin 2 is one of the most potent vasoconstrictors in the body. So it means that an ACE inhibitor blocks the production of a vasoconstrictor. Vasoconstriction increases total peripheral resistance and therefore blood pressure. So if we block the converting enzyme, we reduce angiotensin 2, we reduce the amount of TPR and therefore the blood pressure, right? Your first pharm lecture. That's how an ACE inhibitor works. That's the mechanism of action. Okay, so we got to here. Angiotensin 2, most potent vasoconstrictor in the body, but it also triggers some other things. It triggers renal retention of salt and water through its interaction with aldosterone. Angiotensin 2 stimulates the release of aldosterone. Aldosterone causes sodium excretion and potassium increased sodium excretion and reduced potassium excretion. So all of those things increase arterial pressure, which was our original problem, right? So when the kidney sees low blood pressure, this is what it does. It releases renin, which creates this whole system, which then goes around and elevates pressure so that it can continue to do its function, all right? But proof that it really does matter, okay? So here what we have is we have sodium intake or output, right? Remember, conservation of matter, they have to be the same or we would just get more and more salty, right? So sodium intake or output, here arterial pressure. We can see that, so this is showing you that at a given intake, what's our pressure? We saw those already, that's the acute pressure curve. The key here is the difference. If angiotensin is present, the whole thing shifts to the right. In other words, for the same sodium intake, the pressure is higher, right? That's angiotensin 2's effect. It's a vasoconstrictor. All other things being the same, it's going to move the pressure curve up because of increased total peripheral resistance, right? Now, this graph really shows you why we have a renin-angiotensin-aldosterone system. Okay, one of the most common injuries in nature is a hemorrhage, right? We have circulating blood. That means if we have damage to vessels, we're going to lose blood. Now we get to see why the angiotensin system is good, right? So here we are, happy animal doing normal things, mountain lion, right? Hemorrhage, so we've had an injury, okay? The renin-angiotensin-aldosterone system, when your pressure drops from the hemorrhage, okay, renin will be released. Renin will bring about angiotensin 1, angiotensin 2. Angiotensin 2 is going to cause vasoconstriction. So even though we've lost a bunch of blood, we'll get an increase in our blood pressure because we've increased total peripheral resistance, right? So we're not back up to normal. It's not like we did nothing happened. I mean, we got eaten by, or almost eaten by a mountain lion, right? But we're not dead yet. See, the renin-angiotensin-aldosterone system has kept our pressure high enough that we can maybe still escape, heal, and survive, right? So that's the idea here. If we didn't have the renin-angiotensin-aldosterone system, then our pressure would just be low. We would have no increase in total peripheral resistance, and now we're easy pickings for the mountain lion, right? Because we're not thinking very well, we can't move our muscles very well, all that kind of stuff. So that's why we have it. In nature, losing blood is common. Getting too much plasma volume is weird. That's why most of the time too much plasma volume is us problem. It's iatrogenic, right? So, okay, RAS really does help. Okay, how? What about the salt side of things? So, if we increase our salt intake, we'll get increased extracellular volume. Again, only if we can drink. Okay, salt doesn't make water, but it does make us want water. Okay, so increase our salt, increase our extracellular fluid volume. That's going to increase plasma volume, venous return, cardiac output. Right? So that's going to cause an increase in arterial pressure. That increase in pressure is going to decrease renin and angiotensin. So it works opposite too. That'll lead to a decreased retention of salt and water. So we're going to pee out salt and water. And then that'll bring our plasma volume back down to normal, and we're going to our arterial system, or our arterial pressure will return to normal, right? So what we see here is, okay, X is time. This Y, mean arterial pressure. This Y, sodium intake. This is actually more realistic than you might think. Our sodium intake really does vary dramatically from day to day. Okay, some things have a ton of salt, some things not much. So, here we've got 5, 80, 240, 500. Notice that everything intact, we see very little arterial pressure change despite a very large change in sodium intake. Isn't that fascinating, right? So it means that we as conscious things, we don't have to care how much salt is in the water that we drink or how much salt is in the food that we take in, because we have systems that manage that, right? Now, if we didn't have angiotensin 2, we would see an increase, right? Because as our salt intake increased, our venous return and cardiac output would also increase, which is happening here too, but the difference is in the normal control, total peripheral resistance is being decreased or increased as needed. If angiotensin 2, if we didn't have that system, there would be nothing to turn down, right? So instead, we would just see an increase in arterial pressure with an increase in salt intake. Now, this is pretty arbitrary because we can't actually stop angiotensin 2, so it's made up. This one isn't, though. Here is ACE inhibition. So here we're giving the patient ACE inhibitor. Now, we really do this to people. Here we see that changes in salt do, in fact, have some change in arterial pressure, right? So at a very low salt intake, ACE inhibition can really drop the blood pressure. Look at that. That's almost too low, right? But at medium to higher salt intakes, ACE inhibition still gives us a decrease in arterial pressure, which is what we want.